The bunion, in a simplified way, describes the deformity of the big toe, where the toe points outward and encroach on the other toes. But in reality, this is a very complex deformity. It involves axial and coronal and even rotational deformities, and it has implications much wider than the aesthetics of the toe. It has implications on the weight-bearing distribution across the ball of the foot. It has implications on the arch and on the hind foot alignment. So it's a far more complex problem than just a toe that is deviating outward. There are so many, possibly over 300 different operations described for bunion surgery, but these are all the open techniques, and they utilize different forms of bone cuts to correct the deformity. The keyhole surgery is a completely new technique that is basically performed through a percutaneous cut of the bone, so through the skin, very small cuts in the skin, utilizing specific burrs that generate this cut in the bone. And through this cut, it allows correction of the deformity in all the different planes. And following this cut, the bone is fixed with screws. And again, these screws are placed percutaneously through very small incisions to fix the cut and to allow a stable construct that then would allow the patient to mobilize fairly quickly. And when this technique emerged, the placement of the screws was done under image intensifier guidance. This is still the case, but we now have even a much better way of doing this through a highly accurate targeting device that allows the screws to be placed precisely where they should be. Compared to the open techniques, keyhole bunion surgery carries a lot of advantages. The most common advantage that the patients look for is the aesthetics and the fact that the skin cuts are smaller. But in reality, there are far more benefits than that. So, for example, because the cuts are done percutaneously, it means there is less soft tissue insult and less soft tissue scarring. So this in turn translates into less swelling in the post-operative period. Also, the cuts that are performed outside the joint, which means that the joint itself is not disrupted, and therefore that translates into less stiffness. And that's another major advantage. The fixation is also a very stable fixation. And because it's a stable fixation, it then allows us to mobilize the patients very quickly. So patients are fully weight bearing straight away after surgery. Also, technically, the burrs that we use, they remove a couple of millimeters of bone at the site of the cut. This allows much bigger translations to be undertaken. So basically, we can correct much severe deformities because the bones can be translated to a much higher degree. Lastly, allowing because the cuts are quite small, it allows to combine these techniques with other procedures. So in the past, we would maybe have second thoughts about combining a bunion surgery with other forefoot reconstructions or with hindfoot reconstructions because it's just too much incisions and too much surgery. Whereas now, because these are much minimally invasive approaches and minimally invasive insults to the soft tissues, we can now combine this with other surgeries if needed. So the operation is done as a day case, and after the operation, the foot is wrapped into a bandage. That bandage stays on for the first 2 weeks. You can expect to be fully weight bearing straight away. Patients are given a Velcro shoe to accommodate the bandage, and they're also given crutches if needed. At the 2 weeks mark, they attend the treatment room to have the sutures removed, and at 6 weeks, they come again for a follow-up appointment and x-rays. In the post-operative period, it's quite important to have the leg elevated because that reduces swelling considerably and helps a lot with the recovery. And then walking distances are built up gradually from there. Things like non-impact sports, for example, like swimming and cycling, they usually can be introduced at the 6 weeks post-operative mark. If you think about return to work, it will very much depend on the job. So if somebody's working from home, they can literally be back to work within a couple of days. If the job is a bit more sedentary, then usually they can go back after the 2 weeks mark. For a more physical job, usually it demands 6 to 8 weeks off work before when the bones start to heal. The healing of the bone still takes time. So like open surgery, the bone becomes maybe sticky enough at the 6 weeks mark and it becomes a solid at around 12 weeks. And during that period, there is still up and down swelling happening. So this is something that patients usually need to take in consideration as well. So just like any operation, keyhole bunion surgery has its own risks. So the most common risks, for example, are things like swelling. Swelling lasts for a long period of time, keeps happening on and off for a good while, and ultimately fades away. There is a risk of infection. Infection usually happens as a superficial infection that demands some treatment with antibiotics. And the next thing is wound healing problems. Sometimes because of the use of the burrs, they generate some heat and they cause some focal burn or injury to the skin. This is a technical problem that should be avoided as much as possible by the surgeon. But again, wound healing problems can happen. They might demand dressings on and off for a while until the wounds heal. Things like hematoma formations or blood collections can happen when the patients dangle their foot down for long periods in the very initial post-operative period. So we always advise the patients to keep the foot elevated. There's also a small nerve that runs on the top of the big toe. That nerve can be injured or irritated. Usually it is just upset because of the swelling. And once the swelling subsides, that nerve usually recovers. We also tend to refer to the level of the correction. Undercorrection and overcorrection are possible problems, recurrence of the deformity. Again, bunions or deviation of the big toe can recur maybe in about 5% of patients, particularly if patients choose to wear shoes that can squish the toes together, like the fancy stilettos. So again, patients should avoid those as much as possible. Very rarely the cuts that we produce in the bone can fail to heal. This tends to happen in patients who are heavy smokers. Any other risks are just the generic risks of any procedure, and all risks are generally much less in patients who are fit and healthy, and particularly those who are non-smokers. So again, the key thing is that the patient should be assessed by a foot and ankle consultant who is doing these operations on very regular basis. This is very important. During a consultation, the consultant obviously will obtain a thorough history and will do a thorough clinical examination. There are some red flags that we look for, things that would make this technique not suitable. So some of the key things, for example, are inflammatory problems. If somebody has an inflammatory condition like rheumatoid arthritis, or if some patients have conditions like gout, for example, is uncontrolled. These are things that we have to bear in mind because they need to be managed first, and the treatment could sometimes could need different type of intervention. We also look in the clinical examination for the movement and the mobility of the big toe joint. So if the joint is quite stiff, for example, then that's another red flag. Usually the patient might not be suitable for the technique. Also, patients present with a clear pattern of pain, and whenever the pain pattern is not typical, or whenever the patients present with vague pains, for example, it should be another red flag, because sometimes the pain could be happening because of a different problem in the foot. Even if the patient has a clear bunion deformity, they might be experiencing pain because of problems with their arch, or problems in the forefoot, or tightness of their calf muscles, or other issues. And that's really where it is very important for the patient to be assessed properly.